Hello, everyone. Just waiting on people to join, but welcome to the webinar. Very excited to have everyone here. This is actually my first live webinar. I'm very excited. I'm going to be presenting a lot of really great information, and there's going to be a lot of information. So just bear with me, just take it all in. I'll be emailing out the presentation slides after the webinar. So you don't feel like you're missing anything. Just seeing how many people are on. So I have the Q&A. I should have the Q&A available as well. So you can type in any questions you have during the webinar into the Q&A, and I'll try to get to it at the end. We're scheduled for an hour, hour and a half. We'll see if we can get through all the slides in that time. So just going to give people a little bit more time to get on. Can everyone hear me all right? Just type in the chat if you can hear me. Just anybody. Awesome. Thanks, guys. All right. So we are talking about IBS, one of my favorite topics, because it encompasses so much of general gut health. Let's see if I can, here we go. Let's see, 1 second. Get the slides going. All right, IBS, Irritable Bowel Syndrome, Advanced Topics, Identifying, Treating Root Causes Naturally. I am your host, Dr. Mark Ivanitsky. Sorry, 1 second, let me just, okay. So I'm your host, Dr. Mark Ivanitsky. I'm a naturopathic doctor licensed in California. Also a licensed acupuncturist in New York State. I did my undergrad at Cornell University and med school at NUNM in Portland, Oregon. I'm currently at Tribeca Wellness, where we're offering online Zoom wellness consultations and in-person appointments. And before we get started, just a disclaimer that all the information provided here is for educational purposes only, and that please consult your doctor before starting any new healthcare regimen. And just a little joke to get us started. It's okay, I get irritable sometimes too, says the brain to the gut. So learning objectives for today, we're going to be covering what is IBS, some red flags to look out for. And we're going to be diving into the root causes. We're going to be talking about testing, natural treatments, and at the end, we'll reserve some time for some Q&A. So what is IBS? You know, a lot of people experience this syndrome. The definition is a little bit, as far as functional medicine, the definition kind of varies widely, but in all people, the majority of people who experience IBS, there's a component of chronic abdominal pain and altered bowel movements. The abdominal pain may or may not include also gas and bloating. It's estimated that anywhere between 3 and 20% of Americans experience IBS, and it can be debilitating for some people, and for some people it could just be a minor annoyance. And it's also estimated that around $30 billion a year in healthcare costs are spent on IBS. So it's a big problem. So with chronic abdominal pain, usually the pain is a cramping sensation. It can be located really anywhere in the body. The location varies widely and can range from mild to severe. Usually it's accompanied with a defecation. So there's an urge to go, and the pain is relieved upon defecation. There's usually an emotional stress component for a lot of people. Abdominal bloating is very common for IBS patients. There's also increased gas production, which forms belching and flatulence. And also a lot of people experience a visceral hypersensitivity, which is a sensation of pain upon palpation or touching. It just feels like an internal sensation of sensitivity and pain. Altered bowel habits can vary from diarrhea to constipation, and then altered diarrhea and constipation. For diarrhea, it's increased frequency of loose stools. Normal bowel movements for most people are 1 to 2 healthy, well-formed bowel movements per day. With IBS, people are having upwards of 4, 5, 6 in rapid succession, sometimes bowel movements in the morning and throughout the day. For some people, it's constipation though, and they experience bowel movements very infrequently, maybe every other day or every 3 days. It could be either or it could be a combination of the two. As far as a formal definition, there's the Rome 4 criteria for IBS, which defines IBS as recurrent abdominal pain, on average at least 1 day per week in the last 3 months, associated with 2 or more of the following criteria. Related to defecation, associated with the change in frequency of stool, and associated with the change in the form or appearance of the stool. And the criteria must be for at least 3 months, and symptoms onset at least 6 months prior to diagnosis. So as far as classifying bowel movements, there's the Bristol Stool Form Scale. And a healthy bowel movement should be a type 3 or type 4. Sausage-like stool, brown in color, long formation. When you're in the type 1 or type 2, that's the more constipated stools. You have the hard lumps, kind of look like rabbit pellets, or kind of clumpy sausage-shaped lumps. Looser stools tend to form and get into the type 4, type 5, type 5, type 6, type 7, where there's soft blobs, there's just watery, and then type 7 is really the most watery or liquid diarrhea. So as far as classifying subtypes, there's IBS predominant constipation, like we talked about with Bristol stool types 1 and 2. There's IBS predominant diarrhea, which is more 6 or 7. There's mixed diarrhea bowel types, which have alternating diarrhea and constipation. And then there's anything that doesn't fall within those categories is classified as unclassified IBS. And as far as really digging down into a diagnosis, the Bristol stool percentages of time that your bowel movement forms into these categories gives us an idea of where you land. If it's 25% or more constipation, you're in the IBS-C. If it's 25% or more looser stools and diarrhea, 6, 7 Bristol types, and then if it falls between those, it's IBS mixed, and then if it falls below 25%, you fall into the IBS unclassified category. So some important things to really look out for with IBS is age of onset after 50. Usually IBS isn't diagnosed in later stages. If it is, there's more concern that potentially it could be something more serious like inflammatory bowel disease, IBD, or cancer. So you need to really watch out for that. Rectal bleeding or melena, which melena is a dark colored stool. If your stool is black in color or consistently red in color, it's something to be concerned about. Usually, I would say for most people clinically, when they have some red in their stool, it's likely a hemorrhoid, but you need to rule out something more serious. Large amounts of mucus. There can be mucus present in IBS bowel movements, but a large amount is going to be indicative of more inflammatory bowel disease. Diarrhea that occurs at night is something to look out for. Usually diarrhea occurring at night it can be indicative of something a little more serious. Progressive abdominal pain. If the pain that you're experiencing keeps getting worse or increases in severity, that's another red flag. Any unexplained weight loss is another big red flag. That could potentially also mean cancer, either in the colon or somewhere else in the body. Laboratory abnormalities. So on a blood workup, if you have iron deficiency anemia, usually signifying you're losing a lot of blood. Elevated C-reactive protein also could be signifying of IBD. And fecal calprotectin lactoferrin also signifying inflammatory bowel disease, more serious autoimmune condition of the gut rather than more functional IBS, which is what we're talking about. And then a family history of IBD as well is indicative of more serious red flag. So now to the meat and potatoes of the talk, root causes. So root causes are vast for IBS. And we'll be talking about all these, but really, in terms of frequency you see in clinical practice, the top half of the list is really what you see more of as opposed to the less recognized causes. But pharmaceuticals play a big role. SIBO is a growing diagnosis that's playing a large role in IBS. CFO, small intestinal fungal overgrowth, is another big major cause. Hypothyroidism and hyperthyroidism is something that is often overlooked, but it's a simple, sometimes overlooked diagnosis that can cause loose stools or constipation. We'll be talking about post-infectious IBS, which is IBS after an acute viral or bacterial gastroenteritis. Gut dysbiosis. So SIBO and SIFO are when good bacteria or good fungus overgrow in the small intestine, and a gut dysbiosis is when you've got an overgrowth of parasitic bad guys in the gut. So bacterial pathogens, viral pathogens, fungal, protozoan, or helminth worms, all can cause symptoms of IBS. H. pylori is a bacteria that occurs in the upper GI, but it can cause symptoms of IBS, and it needs to be treated specially because of its severity and its linkage to different cancers of the stomach and GI system. Stress plays a big role. I would actually put stress in the top half of this list. It plays a big player because of the increased sympathetic tone that gets created in the gut, which doesn't allow for digestion and then creates more loose stools and undigested food that feed some of the bacteria and dysbiosis. Food intolerances, this is actually pretty common as well. Lactose, fructose, gluten being the trigger for celiac disease, where those patients cannot digest gluten, and when they have gluten, it damages their GI tract. Food allergies are IgE mediated, frank histamine reactions to foods, and can actually have systemic symptoms as well, need to be looked at. Food sensitivities or IgE mediated delayed hypersensitivity reactions are actually more common food type sensitivity. And we'll also talk about mold, mycotoxins, Lyme, and heavy metals as potential causes of IBS that are often overlooked but are really important. So as far as drugs, there are a lot of drugs that can cause diarrhea. And as you can see here, the list is pretty extensive. A lot of patients are on these drugs, and unbeknownst to them, unknowingly, they're taking them and they're getting symptoms of IBS, and they just really need to dig into to see what everyone's taking and take this into consideration. ACE inhibitors are a very common medication that a lot of people are on. A lot of the anticholinergics, histamine, Benadryl, beta blockers, these are all very common medications a lot of people are on. Metformin is another medication. Synthroid, a lot of people are on Synthroid, and overdosing of Synthroid can actually cause diarrhea and loose stools. Ibuprofen can actually cause it as well. Naproxen, a lot of antibiotics can cause loose stools and mimic IBS-like symptoms. Magnesium, vitamin C. These are all things that need to be looked at, considered before making a diagnosis. And drugs that cause constipation. So there are a lot in this class as well. Opioids are a big one. Iron supplements, barium, antihistamines, again, can also cause more constipation-like symptoms. 5-HTP3 agonists, which are actually sometimes used in patients who have diarrhea to actually constipate them and pharmaceutically. So SIBO, up to 78% of patients with IBS have SIBO as an underlying root cause. This is a big underlying cause for many people. It's categorized by an overgrowth of commensal non-pathogenic bacteria in the small intestine that migrate up from the large intestine. So these are normally occurring healthy, good guys in the large intestine that for various reasons make their way up into the small intestine. Small intestine is usually clear of large amounts of fungus and bacteria. So having large amounts of bacteria in there is going to create an overgrowth and create symptoms of IBS. There are a lot of predisposing factors for SIBO: abdominal surgeries, damage to the enteric nervous system, hernias, diverticulosis, and ileocecal valve dysfunction all can predispose somebody to SIBO. This was a really cool study if you wanted to look into SIBO as a root cause of IBS. It's actually the quoted study I used for the 78% of patients with diagnosed IBS. And it digs deeper into some of the predisposing factors. Female gender, older age, diarrhea predominant IBS, bloating, flatulence, proton pump inhibitor use, narcotic use, and low hemoglobin are all associated with SIBO among IBS patients. So there's a normal physiology which we have, which normally would prevent an overgrowth of bacteria in the small intestine. That is our digestive enzymes. We secrete gastric juices, bile, and these have an antibacterial property in addition to breaking down our normal peristaltic movement in the flow from mouth to anus is moving bacteria along so that it never actually really makes it reverse into the small intestine. There's a continuous one-way flow out into the large intestine. So any damage to that flow is going to create a reflux or upward movement of bacteria into the small intestine. Mucin and mucus production by the intestinal epithelial cells provides a barrier against pathogenic bacteria. Gut antibacterial peptides such as defensins also provide a blockage for an overgrowth to occur. And then the ileocecal valve is a valve that connects the large intestine to the small intestine, and it should be working properly, and it should be able to prevent a flow up through the large intestine to the small intestine under normal circumstances. When there's a dysfunction in the ileocecal valve, there is a retrograde flow that can happen. So, you know, sometimes it's a little bit chicken or egg situation with IBS and SIBO, what came first, but there's a change in microbial balance in the gut. There's often a change in permeability, leaky gut that can happen. Motility or the movement of the muscles in the enteric nervous system is damaged. There's an inflammatory reaction or gut immune activation and visceral sensation that happens that IBS causes SIBO, and SIBO can cause with IBS. Something to, I think I had a slide. No, sorry. Something to look at for SIBO in recalcitrant SIBO is something called biofilms. Biofilms are collectives of organisms that form a slimy extracellular mucosal matrix that binds together and provides a barrier, a protective barrier for the SIBO bacteria. Actually, all bacteria can form these biofilms, but in SIBO, it can cause a problem in that the biofilms become resistant to any antimicrobials, pharmaceutical, or herbal or natural. So getting at a biofilm, so this would be the patient you would see clinically. I actually have a patient who, you know, has gone through multiple rounds of antibiotics and is still having symptoms of IBS. Still having symptoms of bloating, has gone through multiple rounds of herbal antimicrobials and still having symptoms. You start to think, oh, that maybe there's a biofilm involved that we need to work on. And in this particular patient, we gave a biofilm buster, medications that are natural medications that work to open up these biofilms, and her symptoms improved dramatically. So anytime you're experiencing recalcitrant or SIBO that's recurring or not being addressed, think of biofilms. And there are a range of biofilm, natural biofilm and pharmaceutical actually biofilm disruptors that we can use, ranging from the more benign or less aggressive to the more aggressive. NAC, alpha lipoic acid, EDTA, bismuth, and black cumin are actually a little bit more stronger. And biofilm dissolving enzymes are sometimes used as a first line and then moved on upwards to more stronger biofilm busters like bismuth and black cumin. So again, you know, repeated antibiotic use can actually encourage the growth of these resistant mucosal biofilms. So on the one hand, pharmaceuticals like Rifaxamin are used to treat and effectively treat SIBO, but repeated use can actually predispose somebody to developing these biofilms. Like I mentioned, if there's relapse or recalcitrant SIBO, consider biofilms. There's no effective test for biofilms. So right now, it's just through clinical observation and symptom picture that you're going to use to diagnose a biofilm. If you try a biofilm buster and the patient gets better, that's also a good sign. If you want to dig deeper into biofilms, I highly suggest Dr. Anderson's biofilm talk. I include the link here. Dr. Anderson is a genius naturopathic doctor who's spoken a lot about SIBO and biofilms in particular. And if you're interested, you're going to find his talks at SIBOdoctor.com. Very, very interesting. SIFO. So up to 25% of patients with unexplained IBS may actually be having SIFO, or small intestine fungal overgrowth, and not small intestine bacterial overgrowth. So this is an overgrowth of naturally occurring fungus in the small intestine. This one, you know, you do, if someone's not responding to traditional antibiotics, then you would think more SIFO for the patient. It's an overgrowth, like I said, of commensal non-pathogenic fungi. Very difficult to diagnose. Duodenal aspirate from an endoscopy is likely the gold standard for many patients. Many of the antimicrobial herbs used for SIBO actually work for SIFO. So as far as natural antimicrobial herbs, that's a win there. If you're going to go the more pharmaceutical route, you need to switch to more antifungals like nystatin, fluconazole for these patients, and rifaximin is not going to work. This is a great article if you want to dig a little deeper into small intestinal fungal overgrowth. Talks a lot about it. This is, I thought, was a great illustration of the different myco-species, or the microbiome all throughout the body. In the colon, you can see the predominant species actually is Candida. And in the small intestine, there really shouldn't be any bacteria at all. Any fungus at all. So I thought this was actually really cool. We're, in addition to being covered by bacteria, we are covered by fungus. So thyroid disease can also be an underlying cause. So hypo, not enough thyroid, can cause symptoms of constipation and bloating. And in these patients, their TSH, or thyroid stimulating hormone, goes up as a way of diagnosing. Thyroid, TSH is the hormone that the brain uses to communicate to the thyroid to let it know how happy it is with the level of thyroid it's receiving. And if it's going up, it means the brain's not happy. So the thyroid is not producing enough hormone, and this can lead to constipation and bloating. Hyper is less common, but is another cause of loose stools and diarrhea. And medications for hypothyroidism can actually create a hyperthyroid situation. And this is actually seen when TSH comes down, when the brain is saying, we've got too much thyroid, we don't need it anymore, let's tone it down, and the TSH value goes down. Clinically useful markers to look at are total T3, free T3, T4, and free T4. A lot of docs don't like to use these and just rely on the TSH, but I found, and a lot of functional medicine docs find, that these are actually useful values to look at as well. Post-infectious IBS. This is actually a really interesting one. This is an IBS that develops after a defined moment after usually an acute gastrointestinal infection. And a recent systemic review and meta-analysis demonstrated that the risk of developing IBS increases 6-fold after an acute gastrointestinal infection and remains elevated for at least 2 to 3 years post-infection. That's big. So, you know, with these patients, what you're going to see is that there's a defining moment. They've had a viral or bacterial gastroenteritis, and then within a few weeks, they develop symptoms of IBS. There's altered gut motility that happens in these patients, increased intestinal permeability, an increase in interchromaffin cells in biopsy, and persistent intestinal inflammation characterized by a number of T lymphocytes, mast cells, and increased expression of pro-inflammatory cytokines. So I thought this is a really cool graphic showing how in a healthy population gets exposed to acute gastroenteritis, the majority of people will recover, but in a small subset, they'll develop post-infectious IBS. And some of the things that can predispose this subset of people to developing IBS is a genetic susceptibility, baseline increase in intestinal inflammation, and an increase in intestinal permeability, altered sensory motor function of the GI tract, so altered enteric nervous system, and the severity of the gastrointestinal gastroenteritis is also indicative of how if there are post-infectious IBS will develop. Psychological and psychiatric disturbance predispose as well, bacterial and viral pathogens, and host factors. Females of a younger age actually are more prone to developing this. Some of the bacteria that are involved, Campylobacter, Shigella, Salmonella, E. coli, 0157H7, are all implicated in post-infectious IBS, but it means unclear whether all organisms confer an equal risk. Viral gastroenteritis appears to be more transient in form than bacterial. And in a lot of these patients, there's a spontaneous and gradual resolution of symptoms. So it's not like more traditional IBS where there's an ongoing problem. For many patients, there's a resolution. Gut healing and anti-inflammatory measures are more useful for these patients than strict pharmaceutical or herbal antimicrobials. This is a really cool study on post-infectious IBS, talking about a lot of things we just mentioned if you wanted to dig deeper. Gut dysbiosis, or infiltration of bad guys. This is when there's an infiltration of bacteria, virus, fungus, protozoans, or worms in the gut that don't belong there and can kind of set up shop and wreak havoc on the guts. So bacterial, we mentioned some of those. Virals, these are also potential causes of the post-infectious IBS. Fungal protozoan parasites, this is actually a big one that gets overlooked for a lot of people. Giardia, Blastocystis hominis, Andilomax, Cyclospora, these are all potential causes of protozoan parasites that can lead to IBS, and worms mentioned here, Necator, Ascaris, Trichurias. This was a really fascinating study, 2018, that the gut microbiome and irritable bowel syndrome, it really digs deep into basically everything we're talking about here. So if you're interested in a study, an article that digs deeper into the dysbiotic causes of IBS, this is a really great article to look at. And I want to mention a little bit about leaky gut. So intestinal hyperpermeability. This is when there's a breakdown in the lining of the gut. So normally the gut has something called tight junctions, where the cells of the GI tract are fit together nice and tight and don't allow pathogens and different antigens from entering the body. In leaky gut, there's a breakdown of that tightness, and the body allows in some different antigens and different factors that can create inflammation and affect the immune system and actually exacerbate symptoms of IBS. So it's a concomitant factor with IBS, and many of the root causes of IBS actually exacerbate or can cause more leaky gut for patients. In some predisposing factors for with antibiotics, you can actually increase the likely chance of developing a leaky gut. NSAID use, stress, alcohol, gut infections, and other factors can easily degrade the intestinal mucosa, weakening the immune system and allowing unwanted toxins to enter circulation, trigger an inflammatory response, and also interfere with the appropriate digestion and absorption of vital nutrients and minerals. H. pylori is another factor that needs to be addressed and looked at for many patients with IBS. It's a bacteria that is linked to ulcers, gastritis, and stomach cancers. It can cause visceral hypersensitivity, or that sensation of internal pain in IBS patients, and can lead to loose stools. The link hasn't been definitive in IBS patients, but there are some good research articles and studies around it, this being one of them. H. pylori infection associated with development of irritable bowel syndrome, if you wanted to look at that. And it found, as a result in this investigation, we consider the presence of H. pylori colony as another important cofactor in the pathogenesis of IBS. So stress is a big player in IBS. Chronic stress creates an increased baseline sympathetic tone, and the body is in a constant fight or flight mode. And as opposed to parasympathetic rest and digest, food doesn't get digested and can feed an overgrowth or trigger and exacerbates their bowel movements. This is a study looking at, a 2014 study looking at the impact of psychological stress on irritable bowel syndrome, and it found it to be a extremely strong connection for many patients. Dietary causes, food intolerances. So these are cases where the body doesn't have the appropriate enzymes to actually digest these foods. And again, it becomes fermentable food for the bacteria in our gut and can create symptoms of IBS. Lactose, fructose, and gluten are the main ones we see in clinical practice for a lot of patients. Food allergies are IgE mediated, are less common, but these are allergies you would see where there's more of a systemic reaction as well, and not just localized to the gut. So people have difficulty breathing, hives, things like that. Food sensitivities, or IgG mediated, are more common, and these are more transient sensitivities to food that have been linked to leaky gut. So addressing that can potentially also address these food sensitivities, but testing around food sensitivities and then removing these specific foods can actually be beneficial for IBS patients. Some less recognized causes. Mold and mycotoxins, Lyme and co-infections, and heavy metals. And before we get kind of dig deeper into these, I wanted to mention that for the majority of these patients who have these as an underlying root cause for their IBS, there's also concomitant clinical picture that these patients have. They usually have severe systemic fatigue, brain fog, joint pain, muscle pains, nervous system symptoms like tingling and numbness, vision and auditory changes, mood changes, depression, anxiety, OCD. These are the patients who have all these symptoms, and then they also have IBS. And then you're thinking, okay, there's likely another underlying cause rather than just strict IBS. This is a really interesting article in the Cellular Infection Microbiology Journal looking at mycotoxin and its effect on our guts and the microbiota of our gut. So the primary exposures we get from mold and mycotoxins are food and water damaged buildings. And food mycotoxins play a big role in the gut because we're exposed directly to them. But mycotoxins that we would experience from water damaged buildings can actually also circulate in our bodies and create damage to the gut. And actually also then when they're expelled through the gallbladder in our bile, they can then also affect the intestine that way. So there are three major mold groups found in food that are considered have an effect on human health. That's Aspergillus, Fusarium, and Penicillium. And in these three groups, there are 5 major mycotoxin groups. And those are Petulian, Fumosins, Aflatoxin, Ochratoxins, Zearalenone, and Triclothecines. So as an example, Fusarium graminarium produce a mycotoxin called deoxyvinyl, which is a type of trichothecene. And it's shown to block SGL1 transport in the lumen of the gut. And this SGLT1 transporters transport glucose in the gut, but they're also responsible for water absorption. And so a damage in the SGLT1 receptor is going to create more water in the stool and lead to diarrhea. The main way that we would contract Fusarium mycotoxins would be through contaminated food, grains being a major component, player in the mycotoxin. And we can actually, even if we don't eat grains, we actually can absorb mycotoxin through animals that eat grain and meat and dairy products from a grain-fed animal. So another reason to eat grass-fed meat and drink grass-fed dairy if you do those things. Mycotoxins decrease something called MSH, or metalanocyte stimulating hormone. Decreased levels of MSH can lead to malabsorption in the gut and cause diarrhea. Mycotoxins actually can also damage enterocytes directly, leading to malabsorption, leaky gut, and loose stools. Ochratoxin A can actually also depress the size of villi, which are the protrusions, or the mucosal protrusions in the small intestine, which help with the absorption of food, and increase apoptosis in the intestinal epithelial cells. The good news is that a healthy microbiome can actually detoxify a lot of mycotoxins. So working on restoring a healthy microbiome is key to the treatment of mycotoxin patients. And then exposure through water damaged buildings is very common. It's becoming more and more common, especially in more humid areas, and it becomes through global warming as everywhere becomes more warm and more damp. There's going to be more mold everywhere. Ochratoxin, aflatoxin, and trichothecene mycotoxins are, again, the major players there. So testing around mycotoxins, urine mycotoxin testing is one great way to see what the total burden in the body is of mycotoxin. You can also look at serum IgG mold antibodies. These are going to be looking more for a sensitivity or allergic reaction to mold antibodies, which some people can have. Serum immune markers such as C4A, TGF-beta, CD57, not 75, CRP, and these are tests that LabCorp can actually do. Nasal swabs for colonization of the sinus. Microbiology DX is a lab that does that to see if there's any colonization in the sinuses. Is the main way that we encounter airborne mycotoxin through the sinuses. So a lot of people, even if they're not experiencing sinus symptoms, can have colonization and mycotoxin exposure in the sinuses. ERMI testing of the home. This is environmental related moldiness index of a home, and can give us an idea if the home you're currently in is moldy. Bioresonance or energetic evaluations like applied kinesiology, BAH, and ART can give a really good idea if this is an underlying cause for you. But again, they're not diagnostic tools. They can just help practitioners in figuring out if this is an underlying cause for patients. Lyme and co-infections. So in the same way that mycotoxin can affect our gut, Lyme can affect the gut in the same way. And a lot of patients with Lyme present with gastrointestinal symptoms. It's a very common occurrence. Similar to intestinal effects of mycotoxins, Lyme toxin can actually affect the gut as well. It's estimated that 60 and 70% of people with Lyme disease actually have SIBO. The Borrelia burgdorferi bacteria, which is the cause of Lyme, has lipoproteins on its surface which interact with toll-like receptors and can compromise and affect the immune system and create inflammation. In an article written on the Journal of Practical Gastroenterology called Bell's Palsy of the Gut and Other GI Manifestations of Lyme-Associated Diseases, Dr. Virginia Scher goes into much deeper length of Lyme and its effect on the gut. And she actually refers to it as Bell's palsy of the gut, in that it's damaging to the enteric nervous system and can create symptoms of IBS. Testing around Lyme, Western blot antibody testing is a major way that the majority of people get tested for Lyme. Hygienics, Lyme and co-infections immunoblot testing is a little bit more sensitive. And there have been studies done showing that it can actually be extremely, way more sensitive than the traditional ELISA Western blot. Armin Labs is a newer type of test that's coming out, and it's looking at active T-cell infections. So this is really more of give us better data into what's going on in terms of active infection versus looking at antibodies. And it's a test that's run out of Germany, and the testing isn't very easy to do. But for practices that are doing it, it's a really great way to diagnose a Lyme. And then bioresonance evaluations, like we discussed, energetic testing, can help practitioners get a better handle on these underlying causes for patients, because a lot of times these more traditional tests aren't super definitive, and so using more energetic bioresonance testing can be really beneficial for practitioners and for patients. Heavy metals can also play a factor. So mercury is extremely antimicrobial. It can actually kill off healthy flora, leading to an overgrowth of fungus. And a lot of patients with mercury toxicity have fungal overgrowths and have symptoms of IBS. Lead, mercury, cadmium can actually also damage the enteric nervous system. There is something called nickel allergic contact mucositis, which is really interesting, and I'll talk a little bit more about that. But it's a sensitivity to nickel, which some people have, which goes undiagnosed and presents as IBS. Dental amalgams are one of the main ways in which we get continuous exposure of mercury. So dental amalgams that have mercury in them can leak potentially through into the GI tract and create a constant exposure of mercury for the gut, and can be damaging for the enteric nervous system and for the gut microflora. Testing around heavy metals, urine collection, 6 to 24 hour. Some doctors like to do provocative testing pre and post, meaning they give a chelating agent that stimulates the release of mercury and heavy metals into the blood and into the urine. So it can create a spike and let us know what you're dealing in terms of storage of heavy metals. Quicksilver tri-test is a really great test that I've used in the past that uses uses blood, hair, and urine, all three, to triangulate a underlying baseline of mercury and heavy metal exposure in the body. So this is a really great article that I stumbled upon looking at some of everything that we've been talking about, but then also mentioning something called nickel allergic contact mucositis. Is a lot of foods actually in the food system contain low levels of nickel, and there's a large percentage of people who are sensitive to nickel, and foods that are rich in nickel actually are tomato, cocoa, beans, mushrooms, broadleaf vegetables, whole wheat flour, corn, onion, garlic, shellfish, nuts, and foods contained in aluminum boxes. And so then consuming these foods creates a sensitivity reaction in the gut and inflammation in the gut, and then can create symptoms of edema, watery stools, and symptoms of IBS. So it looks like an IBS, but it's really due to a nickel allergy that a lot of people are having in their food. So a lot of these patients will know that they have a sensitivity to nickel, but they may not. So doing testing around nickel sensitivity can be really valuable for many of these patients. As far as testing, so now we're getting into how do we clinically, figure out what's going on as an underlying root cause for our patients. And I really like using GI map. The GI map is the most comprehensive diagnostic tool on the market, I believe. It is a DNA PCR test of the stool and looks at commensal bacteria, dysbiotic flora, bacterial pathogens, candida, fungus, H. pylori, viruses, parasites, digestive markers, immune markers, inflammatory markers, something called zonulin, which is a measure of leaky gut, and even a strain of bacteria called Morganella, which is specific to SIBO. So doing a GI map, you're really covering all your bases, and it's a really, really profound diagnostic tool for practitioners. Just giving you a sample of what a GI map looks like. This patient had elevated C. diff toxin, which can happen, which I have actually seen quite a lot happen acutely, where patients are having mild or severe IBS symptoms, and they're having elevated C. diff toxin. Protozoan parasites, Blastus hominis is a very common one. Giardia, Entamoeba coli, these are all pathogens which the GI map test looks at and can help diagnose. Candidal overgrowth as well, viruses. Normal flora and normal flora species, we can get an idea of high or low. So this can give us some indication of overgrowths. It's not, 100% diagnostic because we can't really tell where the bacteria are coming from in terms of large intestine or small intestine. But it can give us, if we correlate it with symptom picture, it can give us a really good idea of what's going on with the patient. Opportunistic bacteria, Morganella is highly correlated with SIBO overgrowth. Autoimmune triggers, these are bacteria that are in the gut that when they overgrowth can actually interact with our immune system and create autoimmune conditions. So getting a handle on these is actually really important as well. And then digestive, inflammatory, immune markers are really beneficial to let us know. Again, zonulin, this patient had elevated zonulin, so we know that they're dealing with a leaky gut. Anti-gliadin IgA is an antibody in the gut which protects us from overgrowths and from dysbiotic bacteria. And we can look at levels of IgA and see and give us an idea of how well the gut immune system is warding off these bad guys. And then digestive enzymes as well. Beta-glucuronidase is a marker for liver health. Occult blood, we can get an idea of if there's blood in the stool and higher up, can give us an indication if there's underlying inflammatory bowel disease. Just had a patient who had all the symptoms of IBS, but actually when we did a GI map, had really high levels of blood and calprotectin, which are inflammatory markers, and was referred for colonoscopy and actually had early stage inflammatory bowel disease. So as far as gold standard, the gold standard for IBS testing is duodenal aspirate for SIBO. It involves an endoscopy that goes into the duodenum and captures some of the fluid there and can then look at to see levels of different bacteria and fungus to see if there's an overgrowth. Breath testing is something that can be really beneficial. The tests aren't very specific, and they can actually give us a lot of false positives. And so they're useful in terms. Some practitioners like to use them before and after to give us an idea of if an overgrowth has been treated properly, but they're not again not super sensitive. I'm sorry, they're not super specific in a lot of cases. Serological testing for celiac disease is another important something that can be done through serum to diagnose celiac disease. Endoscopy can also be used was more of the gold standard for diagnosing celiac disease. C-reactive protein levels can be measured in the serum to give us an idea of inflammation. Anti-cytolethal distending toxin B and antivinculin are newer markers on the scene, which are really interesting in that they are serum markers for SIBO and IBS. They actually are used to distinguish between IBD and IBS. IBS. This was going back to breath testing. This was a sample hydrogen methane breath test for SIBO. You can see an elevation above baseline for hydrogen, which is more of the gas that's produced in IBS-D or IBS diarrhea patients. And then methane is the gas that's produced more in IBS-C or constipation patients. This patient actually has a combination of the two. And so these patients are given a lactulose, which is a type of sugar that's not absorbed and it's just consumed by the gut bacteria. And then they consume it and they produce gas. And then by collecting the gas in vials at different time intervals, we can get an idea of how high the gas is being spiked and give us an idea of the level of overgrowth in the gut. It's a really effective tool for practitioners who like to use it. And as I mentioned, cytolethal distending toxin B and antiviculin antibodies. I just had a patient bring this into me from another practitioner who ran it for them. And this is a study looking at whether it can be useful at distinguishing between the healthy controls in IBS patients versus IBD patients. And what they found was it didn't confirm anti-cytolethal distending toxin discriminated well between IBS diarrhea from organic GI disease. However, it was able to distinguish between IBS and healthy controls. Additional IBS testing, you can look at food allergy sensitivity testing. There's serum, IgE, and IgG testing we can do through a company called Meridian Valley. There are different companies that do it. This is one that I have used in the past. And bioresonance evaluations. These are, I mentioned previously, energetic resonance testing modalities that some practitioners like to use, like applied kinesiology, muscle testing, BAH, using a Lecker antenna, ART. These are all can be helpful to better understand individuals' underlying causes and tailor make a roadmap for a treatment roadmap for the patients. And it's not diagnostic, but it can be very, very helpful for practitioners who know how to use these tools. And additional testing around mold, heavy metals, and Lyme when appropriate. And this is not in all cases where you would run those tests, but when indicated, you should consider those. So treatments are vast, and we're going to go over that and see timing wise. We still have some time. Good. So pharmaceuticals, briefly touch on that, and then we're going to just dive deeper into more natural treatments for IBS. As far as pharmaceuticals, there are antibiotics for more SIBO patients, Rifaxamin, Neomycin, Metronidazole, Linea. There are anti-constipation medications, Linzess, polyethanol glycol. There are anti-diarrheal agents which stop diarrhea, loperamide. Again, these are all symptomatic control. Antispasmodics, which help to calm spasms in IBS-D patients. Again, symptomatic control. There are promotility agents for people with more of the IBS-C or constipation type, with erythromycin, LDN, and cisapride. Antidepressants in patients where there's a concomitant mental emotional component that can be really beneficial, and then thyroid medications. One thing I forgot to include here would be antifungals as well for more SIFO patients, like nystatin and fluconazole. As far as diet, so diet can play a big role in IBS treatment. The thing about diet, though, is that I see a lot of times patients think of diet as a cure or as something they need to be on forever. The diet really helps us get a handle on symptoms, but it doesn't really treat underlying cause. It can starve out some bacteria in case of SIBO or even fungal overgrowths in SIFO, but it's not really getting to the dysbiosis. So I like to use these diets because it can be really, really fast and effective in a lot of patients. So low FODMAPs. FODMAPs are fermentable carbohydrates, foods that are high in fermentable carbohydrates, which can cause gas and bloating symptoms and symptoms of IBS. So limiting these foods can actually decrease those symptoms. The specific carbohydrate diet, or the SCD diet, is more indicated for IBD patients, inflammatory bowel disease, but can be beneficial for IBS as well. And the anti-candida diet, beneficial for more SIFO type patients. Fiber for more IBS-C patients. Eliminating specific food sensitivities and tolerances is important for certain individuals. And then improving digestion of food is really key for a lot of people. So ensuring optimal digestion through the use of bitters, which actually stimulate your body's own production of digestive enzymes, or giving exogenous digestive enzymes in the form of ox bile, HCl, or pancreatic enzymes can help break down food and make them less available for dysbiosis in the gut, and can lower symptoms of IBS. This is a great study on looking at the efficacy of low FODMAPs in IBS patients and found strong evidence supporting its use, but further studies are needed to be done to understand any potential adverse effects of a long-term use of low FODMAP. So I personally don't like to use low FODMAPs long term, but again, in the short term, it can be very beneficial. So some foods high in FODMAPs is a list here of foods that you're going to want to eliminate if you're going to be doing a low FODMAP diet. Some foods lower in FODMAPs, beef, chicken, lamb, vegetables that are low in FODMAPs. You can see listed here. Some grains are lower FODMAPs. What's great is that a low FODMAP diet, there's a lot of overlap with the specific carbohydrate diet and anti-candida diet. So for a lot of patients, if you don't really know the underlying cause, starting them on a low FODMAPs or anti-candida is actually going to give them a benefit. So antimicrobials that you would use for an overgrowth if you wanted to actually kill in the same way you would use a pharmaceutical: berberine, allicin, oregano, grapefruit seed extract, olive leaf, thyme, black walnut, mastic gum, neem, umeboshi plums. These are all great herbal, broad spectrum antimicrobials that are going to kind of cut back on the weeds of the overgrowth that's happening in the gut. And also, if there's a dysbiosis of bad guys, it's also actually going to get at them as well. Biofilm busting agents, I mean, ought to consider, we mentioned this previously, NAC, alpha lipoic acid, ETA, bismuth, and black cumin, and then biofilm enzyme dissolvers are something to consider. Constitutional homeopathy in these patients who have gas, bloating, diarrhea. There's a symptom picture of different remedies that matches that. So you'd have to know constitutional homeopathy to pick the right remedy, but these are all the remedies that are high likelihood usage in these patients, and then different potencies that you can try. Detox and drainage remedies. These are remedies that I love and I use in my practice with a lot of patients. These are really great at stimulating the organs of elimination, helping to detoxify the body, helping to naturally support our organ systems rather than killing or pushing or forcing anything. These are designed, combination herbal, homeopathic, and metal remedies designed to stimulate and support the natural self-regulation of these organs. The different companies that I've used and really like are Unda, Hevert, Saluna, Picana, Nesmin, and Aranobili. Some words about gut healing. So there, in terms of treatment of IBS, there's the antimicrobial route you can take, where you're trying to cut back and kill the guys that are overgrowing and dysbiosis, or you can work on healing the gut. And more what I'm finding in my practice is that patients respond, whether or not they've been through rounds of antimicrobials, they really respond more to gut healing than they do to killing off overgrowth. So in terms of gut healing, there are a lot of strategies we can apply. I'll be talking about some of these today. Probiotics, in terms of probiotics, there are different strategies here as well. I really love spore-based probiotics because they not only help to heal and support the immune system directly, they also actually help support the other species like Lactobacillus and Bifidobacterium and Saccharomyces from these are naturally occurring species that the bacillus spore-based probiotics help to support. So by giving a spore base, you're actually helping these other species as well. Prebiotics, these are actually they tend to be higher FODMAP foods, which is interesting. There actually have been studies on this that long-term use of prebiotics can actually be beneficial in IBS. Even in the short term, there's an increase in symptoms. More long-term, because they are feeding our good guys, that they can be beneficial. Colostrum is derived usually from cows. It's globulin that has different enzymes and immune modulating factors. Direct immunoglobulins that have been purified and concentrated from bovine serum is something I really like to use. These help support the immune system of the gut, and it can actually act as binders as well to bind up toxin in the gut. They're also non-dairy, so people with dairy sensitivities can actually take them. Peptides is something new out in the market. Peptide therapies, something called BPC-157, is a peptide that is taken orally, can help to stimulate wound healing in all the body, but then it actually helps to heal up the gut intestinal lining. So it's been used for patients with SIBO and IBS. Different amino acids which are necessary for healing the gut. Zinc L-carnosine, which is been studied to help heal up leaky gut as well. Different herbs that provide a soothing demulcent capabilities in the gut, and actually are high in prebiotics, are aloe, slippery elm, marshmallow, chamomile. These are herbs I like to use as well. Humic acids. These are substances which aren't necessarily probiotics or prebiotics, but they're more like fertilizer for the soil and help to soil of the gut, help to seal up tight junctions. Product called Restore, which I really like to use. Bone broth, celery juice, and natural promotility agents can also be beneficial at healing the gut. So I mentioned probiotics. So some of the major genuses of probiotics are Lactobacillus and Bifidobacterium. Here's a study showing that the use of these probiotics actually help with IBS symptoms. The main way you get these naturally would be through fermented foods, kefir, sauerkraut, kimchi, kombucha. Spore-based probiotics, these are, again, like I mentioned, really effective at lowering the pH of the intestines, helping with production of fatty acids, butyrate, which are super healing to the gut, anti-inflammatory, and they promote the growth of keystone bacterial species, which are beneficial at anchoring the gut microbiome and prevent dysbiosis from occurring. Prebiotics, we talked a little bit about that and how they can be beneficial, but with prebiotics, it's about timing and knowing when to use a prebiotic. Usually it's more towards the end of a treatment of IBS, because I have noticed that it can exacerbate those early, it can exacerbate symptoms in early treatment of IBS. So I like to give it more towards the end and focus on more lower FODMAPs in the beginning. This is a really cool graphic on the difference between fiber and prebiotics. So there is a difference. A lot of times that people confuse the two, but fibers are more undigestible carbohydrates found in plants, and prebiotics fall under that category, but then also can be digested by the body and then are digested by the bacteria in our gut. And kind of the spectrum of insoluble, soluble fiber and its effect on the gut microbiome to more fiber-based prebiotics, and then the non-fiber prebiotics. As you can see here, this is a really cool chart to kind of distinguish those two categories. Concentrated immunoglobulins, I talked a little bit about this. These are bovine-derived IgG molecules and proteins that help to heal up the gut, help bind up a toxin in the gut, specifically mycotoxin. If there's mycotoxin, you really want to consider IgG immunoglobulin as a binder. And they're just really fantastic. The more I learn about them, the more excited I get about them. Amino acids we talked about to help heal up tight junctions. Glutamine being a major one. Glutamine and post-infectious IBS. There's a study that was done showing that glutamine use in large randomized controlled trials helped heal up the gut in these patients with IBS. Zinc carnosine, the same. Here's a study looking at zinc carnosine as a healer of the gut and stimulate of gut repair. Peptide PPC157 is something I discussed. It's a pharmaceutical, naturally occurring peptide. Well, it's an amino acid sequence, so it's natural in that it's not a drug, but it is compounded in a pharmacy and needs to be gotten through a doctor. And they're taken orally and can heal up gut. And been at studies on IBS and leaky gut syndrome. There's a study on humic acid and its ability to heal up leaky gut and to heal the gut, if you want to dig deeper there. And other root cause treatments. So this is where I would dig in if the patient had some of these underlying causes as the cause of their IBS. Mold and mycotoxin treatment. So detoxifying the body first, working on supporting the organs of elimination. Gut binding would be a next step when you're working on removing mycotoxins. So charcoal, IgG, clay, zeolite, silica, these are all binders that help remove mycotoxin from the body. And then moving on to phospholipid therapies, these are more advanced therapies which help to rebuild the mitochondria and the membranes of our cells. Sinus support is really important in mold and mycotoxin patients. Some practitioners do this with everyone, even if there isn't any particular sinus symptomology in a mold patient, just to be on the safer side. And then home and building remediation is going to be really important for mold patients. In treating Lyme, working on detoxifying the body is key as well. Supporting the organs of elimination, the kidney, the livers, lymphatics, through different means, glutathione, NAC, and milk thistle. These are really important in helping to detoxify and drain the body. As we then introduce antimicrobials, either pharmaceutical or natural, biofilm busters, the body is more primed to receive those antimicrobial therapies, and there's less die-off and Herxing reaction in these patients when they've been primed with detoxification. Oxidative IV therapies, ozone, UVB, laser therapies, intravenous laser therapies are also really important in Lyme patients. And this is a completely separate topic, but there's a lot to say on Lyme. So I just want to touch a little bit about it here with IBS patients, because for some patients it is key. And then heavy metal removal, detoxification support again, supporting the organs of elimination, and then binding and chelating out through either oral intravenous agents, binding and chelating heavy metals in the body. So just some symptomatic control that can be useful for patients. I like to use, while we're treating the underlying causes, some natural symptom control. IB Guard, which is an enteric-coated peppermint oil I really like to use with patients. Beano, digestive enzymes, bitters, activated charcoal can all be beneficial at symptomatically controlling gas and bloating for patients. Stress management is key, another key factor for a lot of patients. I mean, it's important for everybody, but particularly for IBS patients to get a handle on stress. Psychotherapy, cognitive behavioral therapy, CBT, EFT, EMDR, breathing, meditation, yoga, hypnosis, journaling, calming herbs, essential oils, and nutrients. Some of my favorites to use with patients are lavender, ashwagandha, lemon balm, passion flower, avena sativa, CBD, valerian, L-theanine, chamomile, peppermint, GABA, magnesium, and 5-HTP are really great. Quickly, I wanted to touch on some really interesting treatment, something called fecal microbial transplant. This is primarily used in C. diff patients, but there are more and more studies coming out for IBS and IBD patients. So this involves the transfer of healthy fecal sample from patients to infected patients as a way of reintroducing healthy microbiota into IBS and IBD patients. And there are newer studies coming out that this is really, really beneficial. So it's either done through endoscopy, where they go in through the mouth and they seed the area of the duodenum with the fecal transplant, or through colonoscopy and through the distal ileum is where they're transplanted. So in an open study of 13 patients with IBS, Rome 3 criteria, who received a distal duodenal proximal jejunal fecal microbial transplant, a total of 70% of patients reported resolution of their symptoms. And in another study, up to 75% achieved adequate relief of global IBS symptoms, and 78% still had relief up to a year later. So this is something really interesting. You can actually also take it in desiccated capsule form. And I think this is becoming more and more of a popular treatment as more and more studies come out on its use. Acupuncture is very beneficial for not only calming the system, but actually helping to address some of the underlying energetic causes of IBS. And in Chinese medicine, we say that there are different acupuncture points and herbs that can be used to strengthen stomach and spleen qi, or spleen energy. and dispel damp, heat, and from the large intestine, which is the way that IBS manifests itself. Chinese medicine is based on symptom manifestation and creates really great categories and great language around the diagnosis of different Western conditions. But it's really beneficial, and working on different acupuncture points and acupressure points at relieving damp, relieving heat, and strengthening the stomach and spleen is very beneficial for addressing IBS. And they've actually done meta-analysis on acupuncture. Meta-analysis is a study of studies, and they find that it is really beneficial at reducing symptoms of IBS. Physical activity is something else that's really important. Up to 20 to 60 minutes per day of vigorous, 20 to 60 minutes of vigorous activity up to 3 to 5 days a week has been studied as an effective treatment for IBS patients compared to people who remain sedentary. This was actually a really cool study looking at that and proving that increased physical activity had positive long-term benefits on IBS symptom picture and physiological symptoms. And that is it for the presentation. I hope you enjoyed it. I hope I didn't run everything too fast. Little joke here. I'm afraid that your irritable bowel syndrome has progressed. You now have furious and vindictive bowel syndrome. Here are the references which I used. If I included a PDF image of a study in one of the slides, then I didn't list it in the references section, but you can use the image PDF as a reference. And as far as next steps, so if you're experiencing symptoms of unmanaged or diagnosed IBS and would like to work with me directly, you can call or text Tribeca Wellness. Here's the number, 646-833-8331, or email info@tribecawellness.com. And I am offering free 15-minute consults for patients, prospective patients who would like to work with me to get an idea of your underlying health history and seeing if we would be a good match to work together. For New York State residents, I offer in-person appointments at Tribeca Wellness, and then for out-of-state patients or patients with a personal preference to work remotely, I also offer Zoom appointments. And Tribeca Wellness is a great place. I work with some amazing docs. It's a collaborative team effort that we have going on there, which is really great. Dr. Josh Tresh, MD, and Dr. Erica Walters are two amazing functional medicine docs, and we all collaborate on many of our patients in a hive mind to get at the best treatment and best care for our patients. So that is it. Thank you for attending, and I am going to answer any Q&A questions you may have. Let me see if I can get to Q&A. One second. IBS and ulcerative colitis. So they are not the same. IBS is irritable bowel syndrome, and it is more of a functional, you could say potentially maybe a less serious functional GI disease. And ulcerative colitis is an IBD, or inflammatory bowel disease, and it is a more serious inflammation and infection, autoimmune condition of the gut, which is characterized by mucosal irritation. So when they do an endoscopy, when they do a colonoscopy, they can see lesions in the large intestine, which is diagnostic for ulcerative colitis. So they are not the same. How to heal ulcerative colitis with supplements. So ulcerative colitis, luckily a lot of the gut healing things that I talked about with IBS work really well with inflammatory bowel disease as well. So in terms of diet, we talked about low FODMAPS diet, but a SCD diet, a specific carbohydrate diet, which is a little tweak on the low FODMAPs, has been more useful for IBD or ulcerative colitis patients. But then working on rebuilding the microbiome of the gut, is really important for IBD patients. working with different gut healing modalities is going to be key. But yeah, it's a more severe than just regular IBS. As far as ulcerative colitis diagnosis, you really need to get a colonoscopy. That's the only really way to diagnose ulcerative colitis. It's really not symptomatically, clinically, you would see a lot of blood or mucus in the stool, and so that way distinguish it between IBS, and that's going to be a sign that you need to seek medical attention. Would you ever use biofilm busters preventatively? For example, if you're using Rifaxamin, you add in a mild biofilm buster like NAC to prevent formation of biofilms? I think so. I think it could be beneficial. Yeah, I don't see why not. As a more mild one, I think that's a good idea. For pathogens, how to use oregano oil? I like oregano oil. I like a product called ADP, which is a concentrated oregano oil. It is very powerful. I would need to work with you directly in terms of titrating the dose to see if it could be how we would dose it. But usually you can. There's never wrong in going slow and low and taking it from there, and then seeing how you respond. Any diagnostic tests for SIBO? Do they produce hydrogen or methane? So no, the overgrowth of fungus in the gut does not produce gas in the same way that a bacterial overgrowth will. So it's really difficult to diagnose SIBO actually effectively. What you could do is, if you're treating IBS as SIBO and the patient is not responding, that's a good sign that potentially that you're dealing with a fungus. And then if you try more antifungals and they respond well, then that's again clinically a sign that you're dealing more with a fungus versus a bacterial overgrowth. In order to get tested, I should ask a doctor to do the GI map that shows all 8 categories you spoke about. Yes, the GI map needs to be ordered through a doctor. It is my favorite test to use for pretty much all gut health patients because it gives us so much great information. But again, the doctor really needs to know how to interpret it. There is some nuance behind the GI map, but it is my favorite, and I use it predominantly over breath testing because breath testing is actually difficult for a lot of patients to do. It's not as easy as it sounds. The collection is pretty difficult. Stool collection is no walk in the park either, but it's better than it's easier than breath testing. Recent got diagnosed with nightshade allergies. Can this be cured? Well, if it's an IgE mediated allergy, then those are more difficult to necessarily cure. If it's more of an IgG reaction, then you can actually. There are healing up the gut, working on a lot of the gut healing things we talked about can potentially reverse food sensitivities, like I mentioned. A lot of times with food sensitivities, a patient has leaky gut, and that's the major underlying cause. So a lot of these antigens or proteins from food get into our system and create an immune reaction that necessarily wouldn't be there if the gut was healthy. So working on rebuilding, repairing the gut is going to be key for these patients, and then potentially retesting to see how they do, even with nightshades. All right, I think that is it in terms of questions. I can't seem to find. Sorry, I think we got a couple more. In the chat. Yes, I will be making this available on YouTube, and I will be sending out slides to everyone who registered. So thank you very much for attending, and hope you found this useful. And again, if you'd like to work with me directly, just reach out to Tribeca Wellness, and we can get you scheduled for a consult. Thank you very much, everyone, and have a good night.